Hi everyone, it's Nicole from the Physio crew. Sorry we're starting a few minutes late. I had a few technical problems. I forgot that you can't do Facebook Lives off the computer. Thought it might be a bit easier because I've got this whole list of questions that people have sent in and people have been asking on forums as well. So thought it'd be a really good opportunity to talk about hip pain. I know a lot of people are at home in the lockdown at the moment and not able to access services in the same way, and so maybe I can just bring a little bit of help in terms of my physio knowledge to help you to relieve pain and to understand why you might be experiencing a bit of pain too. So to get us started, let me just have a little look here because I've got a little list of these. Now, a lot of the time with hip pain, it can be from a number of different issues. So it could be that you've had a trauma, perhaps you've had a football injury, perhaps you had a rugby injury. You can get degenerative related pain as well. So as we move into later life, we can get osteoarthritis in the hip. We can get referral into the hip as well. So that can be things like back pain can refer to the hip. We can get piriformis pain, which is muscle in your bottom, which can refer to the front of the hip. So a physio's job really is taking the whole picture, looking at the mechanism of injury, looking at whether there's likely to be any significant damage that may need treating. You know, we do see sportsman's hernia, we do see, which is where you get a little tears that are in the lower abdomen, so we need to go in and sometimes operate on that, not us obviously, but the lovely surgeons, and what things can be treated conservatively. So some things will need surgery, but most things will be able to be treated through physiotherapy. So our role really is to go in and have a little look, find out what the diagnosis is, make sure that it's not coming from the back, because if it's coming from the back and you treat your hip, it's probably not going to help your pain, and to be able to give people these kind of milestones so they know where they're going and they've got a nice clear direction. So we're going to get started with the first question, which can, this is quite a serious question, which is, can hip pain be a sign of cancer? Now, when people come into the clinic, with the physio clinic, whether it's via virtual or in current circumstances, or whether it is actually coming into clinic sort of in person, one of the big things that people really worry about is their pain something serious, and is their pain caused by something sinister like cancer? And that's a very common worry, because of course when we're experiencing significant pain, it's natural for our brains to think of the worst possible case scenario. It's just the way that we're made up. In evolution, we were designed to be able to detect whether there was things that could cause us danger. So whether that particular plant would poison us, or whether this particular animal would try and kill us. So we are always on that kind of sense of alert. Now, the best thing that I can say to you is, if you're worried about having cancer, whether the hip pain could be caused by that, is to speak to your professional. What we look at is we look at red flags. So on a subjective part of the physio assessment, so the subjective part is the talking part, is we look at something called red flags. So red flags are things that indicate whether there's something more sinister going on. And cancer has a particular pattern. So for example, if you've fallen over and injured yourself, it's unlikely to be cancer. It's possible, but it's very unlikely. Things like a combination of questions, like we might ask whether there's been any associated weight loss or loss of appetite. We might ask whether there's any systemic features, like, are you getting night sweats? Remember that these symptoms can be other things as well, like loss of appetite can just be from stress, from pain medications. So we've got to be really, really careful that we're looking at the whole picture. And that's the benefit of when you go to see an expert, is they're looking at experience, so when people come into my clinic and they're getting hip pain, and I see the way that they're moving and I see their age, what we sometimes forget is that I've now probably seen, 1,000 patients with hip pain. So we begin to have these pattern recognitions, and if something doesn't look right, for example, somebody who has hip related pain, which is degenerative, they're going to have tightness in a particular capsular pattern. We'll talk about capsular pattern a bit later. They're going to probably have a very similar onset as I've seen in other people. They may move in a certain way similar to other people. So that pattern recognition is very important. I was on a group this morning back pain group, and there was a woman who was saying that the surgeon had recommended that she had an injection, and she said, well, why is he recommending an injection? Why am I not having surgery? But what she forgets, and it's very difficult because often we think that surgery is going to be the only answer, but what we have to remember is that the doctors started their profession to help people. Like, they want the best care for the person, so they're not trying to stop you having surgery. They're trying to minimize the risk with the maximum amount of gain. So something like having an injection, sometimes what that can do, say for example you're getting pain in your L4-5 nerve root pattern, so that's the area of skin innervated by the nerve root at L4-5 on your back. If they are doing an injection and that relieves your pain, that may give an indication that that's the source of the pain. The problem with things like MRIs in both the hip and the back is there's a lot of false positives. Now, we have to understand that you may be the first one to come back and say, well, hang on, the doctor operated on me and it didn't work because my pain wasn't coming from that area. So there's a system that we use to try and make sure that we are protecting patients and that we're not over treating. And so some of that understanding. So just coming back to that question, can hip pain be a sign of cancer? If you have cancer in the hip, then yes, you can get hip pain. But if you are concerned about that at all, you can either talk to your GP and they can look at doing a check x-ray. But if you were to come in to see a physio, we're autonomous practitioners. We would ask all of the questions that we normally would to rule out whether there was any sinister pathology. And if we were concerned about that, we would refer you with a nice detailed letter to your GP to have an x-ray done just to rule that out. It is worth seeing your GP or paying £40 to get the reassurance. If you're worried that could be cancer, you are best to go and have that worry relieved by talking to a professional, because it could be 10 minutes if you see a GP, 45 minutes if you see a physio of your time, but actually that could give you weeks and weeks, and pain reduces if we're not worried about it as well. If we are fearful or worried, this can sensitize our pain system and increase the pain that we're experiencing. Okay, next one. Can hip pain be muscular? Yes, hip pain can definitely be muscular, and there's lots of muscles around the hip. It'd be quite interesting actually if you Google hip anatomy muscles, you can see that there's lots of different layers. So you've got the things that can give pain. Pain is a perception of the brain, but there are structures that can give something called a noxious stimuli, which is how we experience pain. So things that can do that is the bones itself. You've got the joint capsule, which encompasses the bones. You then have the external rotators, which are sort of these little muscles that are close to the hip joint, and they rotate the leg. You've then got the piriformis mixed in with those. Then you've got your glute min, then you've got your glute med, then you've got your glute max. Everyone knows that one because that's the one that everyone's trying to get with their squats. At the front of the hip, you've got bigger muscles that play a part as well. So you've got your hip flexors, your iliopsoas and your rec fem that go across the hip joint. So we look at the length of those. And you've also got your hamstring that attaches to the back of the pelvis, and that can affect the sort of biomechanics and the way that the muscles are working together around the hip too. So you can get a dysfunction or a tear in any of those muscles. It's uncommon to get tears in some of those muscles, but the common ones are going to be hip flexor tears. You can also get pain from sportsman hernia as well. So that's when you get a tear at the lower abdomen. You can get tears in your hamstring that can affect, and tears in your glute. And you've also got adductors. Sorry, they're not exactly on the hip joint, but they attach right up into the groin. So often, if you have issues there, that can cause problems. The worst one, I'll tell you all the horror stories. The worst one I've ever seen was a really nasty glute tear in a rugby player, and the whole leg went completely black. So normally if you're getting a tear, we'd expect some bleeding, we'd expect some swelling, some pain. You can get little avulsion fractures, which are where a tiny portion of the tendon is the tendon is stronger than the bone and it pulls a tiny little bit of the bone off. So it's not a fracture as such. They call it an avulsion fracture, but it's not like a normal fracture. So say this is the bone, this is the tendon attaching to the bone, you just pulls a tiny little bit off, and again we treat that in a slightly different way. You can also get issues with the tendons. So if you think about anatomy, muscles are the tissue that contract and relax, so that's the things that move us. But the structure of a muscle is not strong enough if you were to attach it straight to a bone. Where the muscle is close, it may cause rubbing and the muscle may be affected. So what the body does, it very cleverly mixes more collagen and it makes the tendon, so the muscle merges into the tendon. That's a very strong, elasticated structure that can store energy, so brilliant for movement and storing energy, and then that itself attaches to the bone, and that's very, very strong. And I think it's really important to remember with hips, because a lot of people think that the body is actually quite sort of weak and vulnerable, and I understand that because pain can be very debilitating, but the muscles and the body are actually inherently strong. If you just Google, I know I always talk about this, but if you go onto YouTube or you Google amazing people, look at the forces that are going through those people. So I'm just having a look at the comments because some things are coming up now. Look at some of the comments that, look at some of the things that those people do. Look at some of the, the backflips, the way that they fall, the way that they recover, the things they're doing on cycling. Even when you're looking at Paralympians, I was looking this incredible man the other day who's on a wheelchair and he's going on a skateboard. The force is going through his body, and potentially if he falls off, we are very resilient, and it's important to remember that most of the time we are strong. It's when we overload our tissues, or when we perhaps fall in a particularly awkward pattern. Think of all the times that you've fallen as a child and you didn't break anything, especially, I can see there's some rugby players on here at the moment, so I won't say any names, but yeah, I've seen you be tackled with full force, with huge momentum, and your body has survived. So we are resilient, but we have to look at how we improve that resilience. So yes, to that question, can hip pain be muscular? Absolutely. How do we fix that? We need to restore strength within the muscle. We need to look at the biomechanics of the hip and make sure that there is balance and strength around the joint. Next one. If anyone who is on the live wants to ask any questions, the comments are popping up at the bottom because I've got this on Instagram as well, but if I miss anything, just write the comment again. So, can hip pain cause diarrhea? That one I don't know. I don't think so. If you were getting incontinence and it was associated with back pain, we would want you to get that checked out. I don't know, that's a bit vague, that one, so maybe I'll answer that one directly back. Can hip pain cause ankle pain? So hip pain, depending on the cause of hip pain, can definitely have a referral. So some hip pain is actually being referred from the back, and that can certainly, if you're getting a referral from the back, so remember, referred pain means that you're feeling it in a location, but the actual source of it is somewhere else. So we wouldn't necessarily treat your hip if the pain was coming from your back. We would look at actually mobilizing and moving your back. Ankle pain, if you are feeling a referral from your back, is normally on the ankle pain that's coming from your back is normally felt on the outside. If it is a hip pattern, then from osteoarthritis, you're much more likely to feel it at the front of the leg as a referral. So again, it's coming from your hip, but you may feel it lower down the leg, and also in the front of your shin. So that's for degenerative or for hip pain. For osteoarthritis, we would be able to tell whether you have that by actually looking at your range of movement and looking at a capsular pattern. Because a lot of people say, well, how can physios possibly know? Don't you need an x-ray to work out whether you have arthritis? But you don't, because a capsular pattern will show us that you're restricted in certain movements more than others, and that helps us to be able to see whether you've got age-related changes. Can hip pain be serious? This is a question that lots of people want to know as well. So when you say serious, anything that prevents you doing what you want to do can definitely perceived as serious. So does it mean that you won't be able to get back to football? Does it mean you won't be able to get back to the things that you love? A lot of the time, our worries and our perceptions of our injury can hold us back, and actually putting it off. So not to be mean, and hopefully don't get into trouble for being gender discriminative, but often men will leave their pain a lot longer than women, and they will maybe be looking on Google and they'll think, oh well, I've tried some exercises, I've tried to do this, it hasn't worked, am I ever going to get back to normal? And one particular example of this is a guy who came through one of our back pain programs, which is an online program where you have a virtual assessment, and he had not been able to run for 6 weeks. He was just back pain. He was getting leg related pain, but it wasn't hip pain. And one of the things that he'd spent was 6 weeks of not being able to do anything, very frustrated because he wasn't able to. Now, in one session, by the end of that 45 minutes, I went over a little bit, so maybe a bit more than 45 minutes, he was then able that evening, bearing in mind he hadn't been able to garden, hadn't been able to do anything for 6 weeks, to go out for a 5-mile run. And that was because the perception was that he may cause injury. Once we actually assess you and look to see, is this in a stage of healing that we need to protect it? Because we know, for a fracture, we need 6 weeks. For ligament problems, we need 8 weeks. For tendon issues, we need to look and assess the risk of whether it will rupture, or if it won't. If it's not high risk of rupture, then we can get you back doing things fairly quickly. So it's the perception of the injury that is very important, and we can help you to know where you're at in that recovery and to push you when it's appropriate to push you, and then to rein you back in when it's not. And I think that's something that people have always been quite surprised when they come in. If they've had second opinions, they've always been a bit surprised. Well, I tend to start quite slow, and then once people have got confidence in that structure, then we start pushing a bit harder. And there's a big gap between the NHS do a fantastic job, but they do have limited resources. And one of the things that I witnessed when I was working is that we would get people to the stage maybe that they could walk and go about their everyday lives, but not get back to being the best of their ability. And physio is such a unique opportunity to help people to improve their lives, to have that moment, that catalyst of change, to say, actually, I'm maybe not living the healthiest life. Maybe I'm not exercising every day. Maybe I'm not achieving the results that I want. Maybe I want to be able to run a bit faster. Maybe I want to be able to run a bit longer. So you've got to look at the much bigger picture. If someone comes in and then goes away after an injury and doesn't exercise because they're too scared or it's painful, that completely sends their life into a completely different course that may mean that they are not as fit and healthy. They may increase their risk of heart diseases, cancer and stroke. So what our job is to actually send people off feeling resilient, feeling strong, so that they can lead a healthier life. Perfect example of this is a wonderful lady who I've seen down in Barnstable. She's now had 2 hip replacements. So inspiring. Now, she was in so much pain that she wasn't able to exercise. She sent me a message the other day, and she has been able to she's been going up in the Valley of the Rock, she's been going up waterfalls, she has been doing incredible things with her 2 new hits. She's had 2 hits within the space of a year. Very inspiring. Her whole life course has now changed because she was able to resolve that pain and then improve and start being healthy again. I've got a few live ones. Let me just hop on here a minute. I don't know if it's going to let me see it. Guys, I'm just going to quickly just come onto my computer, because I'd like to answer the live ones if you're here. Cool. Actually, there is, there's some coming through on Instagram as well, so let me answer those first. So this is from Kathleen. Kathleen, you have put your name publicly, so I hope that's okay to put that. So I have degenerative disc disease, which is within the back. For people that don't know, that's general wear and tear in your back. And my hip is in agony. She's saying, any suggestions on the way to sleep, please? So it's important to remember that degenerative disc disease affects a lot of people. A lot of people will experience it without pain. So I would also recommend that you have a little look online. There is a really good table which shows you the asymptomatic of symptoms of MRI, MRI sort of MRI findings that can be asymptomatic, i.e. you don't have pain. The reason that I tell you about that is I don't want people to get fixed on their MRIs, because actually this lady may have the potential to improve. Just because she's been told that she has degenerative disc disease doesn't mean that she will definitely have pain with that. And that helps to people to understand how we feel pain a little bit more. And there's lots and lots of other educational videos that I'll point you in the direction of. So sleeping is really a huge part of life, and so important in making us feel emotionally okay, and making sure that we have good immune systems, making sure that our healing process. There's lots and lots of studies that have looked at sleep hygiene and how that influences your recovery rate from surgery. So things like making sure that you're not using your phone or any electrical devices an hour before bed, making sure that you do some breathing techniques to lower the sort of sympathetic nervous system if you're feeling anxious can be great to improve sleep quality, making sure that you are making sure there's not loud noises. This can improve sleep quality, and the reference book for that would be Why We Sleep by Matthew Walker. Everybody should read that book. Absolutely fantastic book, and I'd highly recommend that to other people. Now, when we're actually talking about positioning, quite often when we're lying, if we're lying on our side, for example, sometimes the hip won't like it if we are positioned with our legs in slight adduction, which means that if you imagine from your hips to your knees, the knees are slightly in regards to your hips. So a really easy way to position yourself to make that more comfortable is actually to put some pillows in between your knees. So you want to imagine that you draw a line down the middle of your body, and you're trying to stop that hip coming across. Now, so yeah, 2 or 3 pillows can do. Sometimes people have the pregnancy pillows, that can work quite well. Making sure that you're thinking about your pain relief. If you do take pain relief, think about taking it regularly. What often happens is people decide, okay, well, I'll take my pain relief when it gets really, really bad. And sleep can sometimes be a problem, because people can sometimes get off to sleep, but then as the pain relief wears off, then they may get it in the middle of the night. So having pain relief by your bedside, if you're going to take it in the night time, making sure that you've got some food to take with it, and building up that medication within your system. We want to make sure that we are trying to, because we have to remember about conditioning as well. If we are conditioned to think, you know, sometimes nighttime is worse because we have less distractions, we tend to be more still. We know that non-specific lower back pain has an increased incidence for people who spend more than 8 hours in bed. So if that's the case, what we should be doing is making sure that people who get non-specific lower back pain, so that affects 90% of the population. That's back pain that sits in and around your lower back but doesn't affect your legs. So Kathleen, this isn't so relevant for you, but we should be making sure that those people aren't spending more than 8 hours in bed. Getting up and moving regularly, trying to make sure that we're de-threatening the pain system. So one of the things that I've had when I've had muscle spasm in the past, particularly in my back, is when I was waking up, I was sort of lying there and absolutely rigid because I'd been there for so long, and it was very, very painful. So in that instance, deep breathing exercises, making sure we're engaging the diaphragm, and then doing some gentle exercises to try and get those muscles to relax. Remember that pain results in muscle spasm, which results in pain, which results in muscle spasm, which results in pain. So we need to think about how do we break that cycle. Things like having a TENS machine, as long as you haven't got any contraindications, make sure you read the packet, you can have that situated on your back. And so then you've just got it by the side of your bed to turn on when you wake up if there is some discomfort. Okay, just going to come across here to the next question. Any good exercises or stretches to ease the pain associated with femoral acetabular impingement? So for those of you who don't know, femoral acetabular impingement is where you get, if you think about it how it is on an x-ray, I'm going to describe what it is. So you can get something called a cam lesion, which is where you have the femur, which is your thigh bone, and then you have the acetabulum, which is the socket of your hip. Now, sometimes what can happen is you can get irritation of the joint capsule or a tear between the end of this bone here, the acetabulum, and the joint capsule of the hip. Now, this can exist with no pain whatsoever, and that's very important to remember. I will try again to show the figures of MRI and X-ray false positives in the hip. And the reason I emphasize that is quite often people will go straight to surgery with this, and we need to be really careful because surgery can work in some cases, but it doesn't work in all cases, and sometimes the long-term research doesn't support it. So what we want to be doing is looking at, again, regaining mobility and control around the hip. So it may be that we look at activity modification. So for example, I've got a gentleman, he was actually seeing a physio for maybe 2 or 3 months, hadn't been getting quite the results that he wanted, so he came in for a second opinion. And he'd been doing the right kind of exercises, but not with consistency. And he'd also been doing lots of aggravating factors of the hip. So being in lockdown, he was sitting, for example, in chairs where his knee was higher than his hip. So that's going to, if you think about if the hip is at 90 degrees flexion, that is going to put a little bit of pressure and may sensitize the structures at the front of the hip. So what you want to be trying to do is making sure we're minimizing that. That might be creating a stand-up desk. It might be not doing what I'm doing now, which is crossing my legs. It may be looking at the hip flexor length, so doing things like the Thomas test to have a little look at whether the hip flexors may be affecting the position. I had a young lad who was, I think he was 15, this was quite a long time ago now, and it was one of those situations where I actually got quite angry because this young lad who, his mum actually might be watching, so I'll be careful what I say. But yeah, he was a young lad, 15, and the surgeon had said, right, we're going to operate. And he'd come in for physiotherapy as a second opinion. He'd actually had, I think he'd had one NHS treatment, but it had been kind of quite a distance one. They'd given him some exercises. Now, he was experiencing pain at the front of the hip, but when I looked at him and investigated, it didn't make sense. And so I just said to his mum, I just said, could you just give me 6 weeks just to be able to have a little look at this before you guys proceed on with any kind of surgery? Now, within 2 sessions, we were able to resolve 1.5 years worth of pain, 18 months of pain. So they were about to operate on a young lad with the risks that are associated with operations because they had seen this lesion, this labral tear on him. However, the pain was not coming from that region. I was able to do soft tissue work around the iliopsoas. I was able to get him strengthening his glute muscles. We looked at mobility work around it, and I was able to talk to him about just reducing fear and reducing that sensitivity of the pain system. Because if you think a young athlete, 15, told that he's not going to be able to play football, told that he has to stop everything that he's doing, we have to look at patients holistically. We have to look at, well, yes, what are the muscles that are affected? How is the brain interpreting that information? How can we get things stronger, and how can we release areas that may be tight, or we may need to promote blood flow in areas of ischemia? 2 sessions, and that prevented him having surgery. And I think the last time I spoke to his mum was probably about 1 year ago, completely unrelated, and he was still pain-free from that. So make sure that you're looking at all different avenues before we start jumping down the surgery route, because people think that surgery will be beneficial, and sometimes it is, but it's not guaranteed. And actually doing something conservatively, putting your mind to it and saying, right, for the next 6 weeks, 3 months, I'm going to really focus on doing exercises and committing to treatment. You may find that you get the same result, but you don't have to have an anaesthetic. You don't have the risk of having post-op complications. You don't have the risk of potential side effects if things go wrong in the surgery. For example, like we found out with meniscal tears, cartilage tears in the knee, we now know that actually 2 years post-op to having meniscectomies, if you compare physio to surgery, the surgery participants will actually be more likely to get osteoarthritis. So there can be these other consequences that we need to continue studying and researching. Okay, let me see if I can just bring up the next one. Bear with me just a minute. I've got some more coming in on this side here. Okay, so Mandy, I have a L45 anterior posterior fusion in November. Okay, so she's had x-rays, checked the metalwork's okay, had physio and hydro. The hydro has stopped. I'm walking when I can, but it seems to make it worse after. So I think, Mandy, with that, what you want to go back and do is, if you have a physio that you trust, that you've been using before, that knows you, I would just go back and have a little chat with them. It's great that they've done the x-rays to check that there's nothing going on with the metal work. There's lots of reasons that pain can become sensitized, and it's not, you don't want to panic that the fusion hasn't worked, you don't want to panic that there's something else going on. What we have to remember is that if we've been exposed to pain for a long time, there will be an element of conditioning. So for example, I'm going to go into a bit of detail now, and I hope you guys don't get bored because I know I'm supposed to be talking about hips. But if you imagine that you get stung by a bee, I'm going to show up here because there's a few comments at the bottom. When that bee stings you, there's sensory information that goes up to your brain, and your brain decides whether that particular signal is dangerous to you. If the first time that I get stung by a bee, I go into an anaphylactic shock, an allergic reaction, I almost die, the next time the bee stings me, it's exactly the same information that's coming up to my brain. But how do you think my brain will react to that second signal? It will say, well, what happened? The last time you had this chemical signal, what happened to you? You almost died. So the second time I experienced the bee sting, I would get excruciating pain. If that bee stung me every single day for 4-5 months, I don't know how long you had pain before you had the fusion, but imagine if that signal was coming through every single day. What starts to happen is the brain learns pain. So we actually become more sensitive to understanding that particular signal. In the same way that when you see tennis athletes repetitively doing the same stroke, say they're doing a backhand or a forehand, they're repeatedly doing the same things, they become very good at that particular movement pattern. So what I would recommend that you do is go back to your physio and get them just to have a little look at everything. See, to make sure that you're doing proper deep breathing exercises. I've been doing a lot of reading over the last couple of weeks how the diaphragm can actually affect our sympathetic nervous systems and the way that oxygen is carried throughout the body. So helping to relax the diaphragm, helping to be able to lower that sympathetic nervous system, that's your fight or flight, which is what is activated when we're in a state of alert and readiness. So when you see people with back pain or hip pain getting up from a chair, sometimes what they'll be doing is really tight, and you'll see them kind of pushing up on the chair or grabbing something. When you actually challenge the person, you say, is it painful? They'll say no. And you'll say, well, why are you holding on to things? Why are you pushing up and holding on to your legs? And it's because of that very clever brain having a conditioned response, and it's predicting ahead of time. It'd be interesting to know whether you actually experience that yourself, whether you get any of that guarding. And if you are getting that guarding, that's a really good indication that you need to go back to your physio and say, well, how do I stop the guarding? How do I help to desensitize my pain system? Because you can get great long-term results doing that. I think you were saying it's at the top of your leg. You may also just have some tightness in some of those muscles around the hip flexors. So looking at things like the Thomas test, looking at things like a very gentle femoral nerve test. Sometimes we can do these really lovely gentle femoral glides, which will help mobilize the structures as well. And just to help, if there is an area of impingement, we can help get, if for example, the nerve is being slightly compressed. Remember that nerves don't mind being compressed. Every time you bend your elbow, you're compressing a nerve. They just don't like it for long periods of time. So if there is an area of nerve that's compressed, if we can help to move that nerve through the tissue structure, then we can help to promote good blood flow, because the pain is coming from ischemia usually with that. We can promote good blood flow and then help to get you feeling better. So I hope that one's been helpful. Right, next one. If I've been having pins and needles coming down into the arm, what could this be caused by? So, slightly off hip pain, but yeah, we'll talk about pins and needles because it's interesting. So pins and needles is normally an indication that the nerve has been involved, and in the same way that the hip pain can be referred from the back, pins and needles can be referred from the neck, or it can be, sometimes we will get elevation of the first rib, and that can sometimes cause irritation to the nerves coming through the brachial plexus, which is the nerves coming down through the shoulder. So could this be a problem coming from the shoulder or wrist or neck? So all of those. You can get compression in the carpal tunnel of the wrist, you can get compression around the cubital tunnel in your elbow, and you can also get through the shoulder and the neck. So that one might be best to maybe book in a discovery call. We do a 30-minute free consultation, which is just a discovery call. And then if you thought, actually, I want to get more information and spend time actually face-to-face, I say face-to-face with the physio, it's via virtual, but you can book that online. So the consultation is 40, but if you want to just have a chat with a physio, then it's 30 minutes, and then that's free, that's fine. Right, we've got another one that's come up. Let me just refresh that a sec. And then I don't know if I'm going to get through all these. I've got quite a lot of time today, guys. So I was planning to do a hip one, a shoulder one, and all the difference. I've been a bit slack. We've been doing a few virtual consultations, but yeah, I've had a little bit of morning sickness. But today I'm feeling great. So you've got me for as long as you like. So next one, I had an L4-5 decompression surgery in February following 2 years of pain. According to the surgeon, I've inflamed nerve. He was going to decompress by removing bone spurs. I've had slow recovery from my no physio due to lockdown. Nerve has improved, but I'm getting some hip and back pain. Caroline, I would be seeking again that you see if you can get virtual consultation. If the NHS department that's supporting you doesn't do that, then have a look online and find somebody that you trust, because there's lots of, I think with virtual there's a lot of kind of perceived worries that you're not going to be able to do the same thing, but we can, as physios, we can look at activity modification. So it might be, for example, that you're moving, that we need to get you moving in a slightly different way. It could be that you've got a little bit of guarding, could be that we need to do some gentle stretches. The way that you can get irritation around the nerve, if we actually think about the nerve root itself, is sometimes it can be swelling around that nerve root. So sometimes, and that causes the pressure, which leads to the pain. So sometimes actually being able to move can help to release some of that and make it feel easier. In terms of the stretches, we're looking at lots of the muscles in the back can become very overprotective. So there's a lot of myths around back pain that it's all to do with a weak core, that weak core causes back pain. But actually the back when we're in pain is very, very rigid. So what you want to be trying to do is relax those areas and get those areas moving like a chimp. I always say to people, you need to move like a chimp. You see people who don't have pain and they're very fluid in their movement. They can bend down, they can put their shoes on, but people who are in pain are very, very rigid. There's a lot of evidence that shows that it doesn't matter what movement you do with particularly non-specific back pain, but we just have to move. So when we're thinking about hips, be interesting to know whether you're getting it on one side or whether it's both sides, and what exercises you've been doing to try and help to recondition those muscles around your bottom. We start losing muscle, we start having atrophy, so we lose muscle bulk after 12 hours. So it's no wonder if you've had pain that you haven't, and also when we're in pain we don't contract the muscles in the same way through something called pain inhibition. So it's very, very important that you're building strength and resilience, and that you're building confidence in the activities that you're doing as well. So I hope that's helpful. Right, next one. Can hip pain cause back pain? Yes, absolutely. So this is really common when people first go in to see the doc, is they think that it's back pain, but it's actually coming from the hip. And the way in a physio assessment that we would look at that is we look at the range of movement of your hip. We look at things like the Faber's test. We look at whether your mechanism would fit with someone who may have age-related changes. Normally, when I see back pain, which is coming from the hip, often I see that in people with degenerative change. Doesn't mean that you will have that, because it can be referred for other things as well, but that is quite common. You've got a big muscle, your glute, which sits in at the back, and that feeds up. So I wouldn't be surprised at all if there's problems with that muscle, because you've got to think, if you've got hip pain, those muscles aren't necessarily going to be doing their job properly because of pain. You may be moving abnormally. You often see people with pain will sort of have this swagger. We call it a Trendelenburg, and so we're trying to normalize gait patterns. Sometimes it can be as simple as just getting somebody to do heel toe. and getting them to normalise their gait pattern and strengthen the muscles that are weak. So yeah, I hope that's answered that question. When hip pain needs surgery? I think this is an interesting question. I think hip pain needs surgery if you've been through an evidence-based pathway. So have you been to see a physio? I'm going to be biased when I say that, but I would say that even if I wasn't a physio. You want to make sure that you're exhausting conservative management first. You want to make sure that you've done everything in your power. So the kind of thing that we will look at first is we look at a little bit of medical management, we look at activity modification, we look at muscle strengthening, mobility. We use things like a seat belt to help with mobility. We use things like distraction techniques, acupuncture, loads of different tools which have minimal risk. Once we've looked at that, if there has not been significant change, then the next sort of step in your pathway would be an MSK specialist. So they are normally based within the NHS. They can order MRIs or X-rays, and they can then decide whether it's appropriate for you to see a surgeon. The surgeon may decide that they do an injection first, and then if that doesn't work, then perhaps they will look at doing surgery. It is important that we are, this is the information age. There is so much stuff that you can look at online, but what I often find is that actually overwhelms people, because you've got, take the last week, for example. You're getting information from so many different sources, so many biased sources, so many people changing figures, particularly in the current climate. And so everybody will have their own opinion, and you need to try and look at different sources and really come back to the evidence. So look at places like PubMed, or come to people that you know are chartered, so chartered physios, or people who are bound by a professional governing body. If I was to come out and talk about things that weren't evidence-based, I would be breaching a professional conduct. So it's helpful to listen to people who are bound by those professional boundaries, and also to look at the bits of evidence. So for example, when I'm explaining bits of evidence, I often try and link them. So if I'm talking about an age population between 20 and 30 having this particular type of hip surgery, and you're in your 50s, that population, it's not really relevant for you. So it's about starting to understand what studies have been done, what evidence is there for people of your age group with your particular condition, so that you can make informed choices. And going into, if you're having surgery, going into those conversations and asking the surgeon, have I tried everything else that's possible? What other things are available to me? Simple things like, we know weight loss can reduce significantly the amount of people that need to have knee surgery. Well, actually, maybe somebody would choose to pay for a personal trainer, pay for a physio to do exercises, rather than going down the route of having surgery, which then could have, pain and post-op complications. Whereas, yes, doing the personal training may cause a little bit of pain, not necessarily in the knee or the joint that you're trying to help, but it may cause a bit of emotional pain, a little bit of physical pain from doing the exercise, but actually that has had a much bigger impact on your long-term health, and actually hopefully reduce your risk of heart disease, cancer, stroke as well. Thanks, Caroline, for that reply. I appreciate that. Okay. What causes hip pain during pregnancy? Oh, pregnancy. No one tells you about all of the things that happen in pregnancy. And I am now 15 weeks, I think it is. And I've treated many people during pregnancy for both back and hip pain and pelvic pain. And it's been amazing to actually start to understand how the body feels when you're actually experiencing it. And the reason that pregnancy often causes an increase in back pain or hip pain or other musculoskeletal problems is that you begin to release something called relaxin. So relaxin is a hormone that helps the ligaments to literally relax, so that the baby can more easily come out, which is great. That will be helpful. And so when we're looking at sort of hip pain, you may be familiar with hypermobility syndrome, which is where people have more elastin in their ligaments. And so people who are hypermobile and are pregnant can be at risk of having things like joint dislocations or more musculoskeletal pain. And the pain is often coming from either the overstretching of ligaments, but more often it's coming from the muscles having to support around those areas. So for example, things that I've started to feel, which I'm sure no other pregnant person would even notice, but sometimes having having knowledge is not a good thing, is when I'm getting in and out of the car, I can feel a stretch at the front of my pelvis as I bring my leg out. And that's because there's a little ligament at the front of the pelvis that holds the front part of the pelvis together. And I can feel that stretching and having additional pressure on it. Now, if you are having hip pain specifically, it's difficult to know actually whether you're getting, it didn't say on this one, whether you're getting hip pain at the front or the back. And that would help us as a physio to determine whether this is to do with the ligaments being overstretched or whether it's actually the muscles coming out in sympathy and saying, oh, I need a little bit more support. And as a physio, we treat them slightly differently. If you are getting, if it's happening because the ligaments are being overstretched, we can do things like putting a band around the hips to give the pelvis a little bit more stability. We can look at activity modification. So when you're getting in and out of a car, keeping your knees together is really important, so that you're not moving one leg at a different time, causing rotation in the pelvis. The sacroiliac joint only has, I think, 2 or 3 degrees of movement. It's very minimal. This is why when chiropractors are saying, oh, I'm clicking you in and out, it's like, what? No, that doesn't happen. It's only a small amount of movement. And that only increases a tiny bit when we have relaxin and we've got more sort of flexibility in those ligaments. So we give you a little bit more support, we build up the muscle strength around that area, and we help you to understand what things might aggravate. Simple things like having, I'm noticing a little bit more when I'm lying on my side that it can be uncomfortable. Just putting a pillow in between your legs, making sure that when you turn to move, you're moving your legs together. So just a few little tips and tricks there for people who are pregnant. Hi Mandy, I'm just thank you, waiting for your physio start appointment again. Yeah, Mandy, that's great. And if I don't know when outpatients are going to be open, but make sure that because quite often the NHS physios are doing phone consultations, and that might just be able to give you a little bit of advice and help over the phone as well. There's quite a few. Why hip pain during periods? Sorry, we're doing the female ones at the moment. So we can get lots of different referral places for people when they're having their period. Quite often it will be in the back. Sometimes we can get it radiating around towards the hips. And that's because when women are having their periods, you're getting a contraction of muscles as everything is being released down. So that kind of cramping sensation, quite often people don't realise, but that's the muscles that are doing that. And the hip and the buttock pain and the back pain is just a referral of that. So it's nothing to worry about at all. You can talk to your GP if you have any further questions about that one. Why hip pain after running? That's quite a hard one because you can get hip pain after running for lots and lots of different reasons. So my question to that particular person would be, are you getting it after you're doing speed sessions? Are you doing it after you're doing hills? Have you changed your shoes? Have you changed your mileage? Loads and loads of things. So you can get hip pain from the muscle, you can get it from the joint, although that's uncommon if you're running. You could get it because your hip flexors are tight. You could get it because of piriformis. I bet with that one, they're probably just overloading a little bit. The piriformis is getting tight and they're getting a bit of referral at the front. So that one probably just needs an assessment to work out which one. Okay, we'll just take a couple more because we've almost been on here an hour. Will glucosamine help hip pain? Ooh, this is a good one. So glucosamine is not advised by the American Association of Hip and Knee Arthritis. I think that's the name of it, AAMA, I think it's called. And that is because when they look at controlled studies and they compare it to a placebo, they find no significant difference. Now, I know that people, including my dad, use glucosamine and find it very, very effective. Now, I'm not saying that you shouldn't use it. I'm saying that strong evidence doesn't support that it's better than a placebo. I don't mind, and I'm probably getting in trouble for saying this, I don't mind if your pain goes away by you scratching your ear My job as a physio is to get rid of your pain. So I don't mind if you have a particular routine that you do, if you have a particular strategy that works, I have no issue with that. But I think as a professional, we have to be very honest with what we see in terms of evidence. And glucosamine and chondroitin both have not got strong evidence that they are more effective than a placebo. Remember that a placebo is still a physiological response. So the brain is releasing chemicals because we believe it's having an effect, not because it's actually having a direct effect. So you need to decide, is it worth, if you take glucosamine or chondroitin, you need to say, okay, well, I know this could be a placebo response, is it worth my money? And if it gets rid of your pain, you may say that actually, yeah, that's worth my money. Or from a physio point of view, we wouldn't be able to recommend it, but I know my dad uses it and swears by it. But each to their own. At the end of the day, we just want people to be pain-free and healthy, as long as it doesn't have any negative consequences. Obviously, medication, I don't know about specifically chondroitin, glucosamine, but medication does have negative consequences. We look at the opioid problems that we see across the States and in some degree in the UK as well. And we're seeing that I think it's 1 in 10 are getting benefit, or 2 in 10 are getting benefit from these pain relief. So this is gabapentin, tramadol. You have also got, I think they had, so gabapentin, I think amitriptyline was in this particular study group as well, and morphine. So you're getting really nasty side effects, and only a few people, so 9 out of 10, sorry, were getting side effects. 2 out of 10 were getting benefit. So you need to really decide, do I want to be on these medications, and speak to your doctor, because the doctor is the best person to discuss this with, and say, actually, am I still getting the benefit of this without the negative? Now, of course, pain relief is needed in some cases as well. You know, I had a lady who's desperate to come in. We are still not open at the moment due to COVID-19, and I advised that she speak to her doctor about diazepam to help to relax the muscles around her back. And she was saying that she couldn't cope with the consequences of them, of feeling, knocked out and feeling nauseous and sick. But you have to work out in the short term, is that going to benefit you in the long term? If taking it for a day, 2 days compared to taking it for years and years, you need to make those decisions. Okay, I think if anyone is on the live and has any more questions, just ask away, and then I'm going to do one more, and then I'm going to finish there. There's a few. How does hip pain start? That's probably a good one to take us to 12 o'clock. So hip pain can start for loads and loads of different reasons. So it may be that you had a specific trauma, perhaps you fell over and injured the area, perhaps you are moving into later life and it's knocked you off. Maybe you're moving into later life and there's a little bit of degeneration. Remember that doesn't mean you're going to have pain forever. It means we need to mobilize it and get it stronger. It may be that you slipped. It may be a repetitive injury. Lots of the time we see groin injuries in people who, for example, are doing kicking sports, so running or football or rugby. And one of the things that I was doing with somebody to get them back following a groin injury yesterday was running, which is why that was in my brain. Running, so looking at doing snake runs, then looking at doing diagonals, looking at lateral hops. So we take people to quite a high level before they go back to sport. Other causes for hip pain, how does it start, is things like sitting for long periods of time, not for everybody, but for some people, sometimes crossing legs, so activities, maybe doing sports that they haven't done for a while. Anyway, I think that is probably enough. We've been on for an hour now. I hope you've enjoyed it. I really appreciate you watching, and if you have any further questions, just comment in the box below, and if it's been useful, please share with anyone who may have hip pain or anyone who might be interested on your social media. Take care everyone, have a great day. Bye bye.